who blogs regularly at www.aboutbone.com. The topic for today is a distraught housewife and a traveling salesman revolutionize arthritis surgery. For millennia, many people lucky enough to survive into their 60s and 70s have developed wear and tear arthritis, also known as degenerative joint disease or osteoarthritis. When this type of degeneration occurs in fingers, the joints become stiff and knobby and perhaps painful, but with 10 digits on 2 hands and neither hand having the duty to bear body weight, people seem to manage. The state of affairs has always been quite different, however, if the disease affects the hips and grinds away the cartilage there. The thigh bone's ball no longer glides smoothly in the pelvic socket during walking, and especially when the owner tries to rise from a chair or climb stairs. Rather, without slippery cartilage covering the ends of the bones and smoothing things over, raw bone rubs against raw bone and causes great pain with every step. Rising off a commode becomes agonizing. Canes, crutches, and wheelchairs have been the mainstay remedy short of surgery, which initially was primitive and only marginally effective. Even before the discovery of general anesthesia in the 1840s, surgeons at times merely cut off the end of an infected or terribly arthritic thigh bone, possibly relieving pain, but certainly rendering the limb short and unstable, at least for humans. Even today in veterinary practice, however, a standard operation for an arthritic canine hip is to remove the ball end of the thigh bone and leave the hip socket empty. Because dogs share weight bearing among forelimbs, the limp after this resection surgery is hardly noticeable, and the improved mobility is remarkable. With the advent of general anesthesia in the 1840s, surgeons could become more methodical with operations, and they began resurfacing the raw bone interfaces of arthritic hips. Their ingenuity was boundless, and they were not burdened by any concept of informed consent, a 20th century development. Sure, the doctors followed the Hippocratic teaching of first do no harm, but who was to know how various materials implanted between surfaces of an arthritic joint would fare unless somebody tried it? And try it they did, using fat, muscle, celluloid, wax, glass, rubber, and sheets of zinc, magnesium, silver, or gold, even pig bladder. Resurfacing posed several soon discovered problems. First, the body had to tolerate the artificial material rather than spitting it out, either mechanically, immunologically, or both. Resurfacing also failed to restore adequate motion or comfort. This led investigators to try replacing the entire hip joint rather than merely resurfacing the original one. Shaped like hip joints, first rubber, then ivory, then various metallic components were tried, but replacement added another problem to those of resurfacing. The artificial hip joint's components needed to be fixed securely to the patient's pelvic and thigh bones in order to prevent wobbling or pistoning between the implanted components and the bones. By 1891, surgeons had tried securing ivory implants with metal screws, and then with mixtures of plaster of Paris, powdered pumice, and resin. All efforts failed. In the first half of the 20th century, multiple European and American orthopedic innovators experimented with different fixation techniques and with variously configured total hip components made from different metal alloys. It was Englishman John Charnley who brought total hip replacement into practical and widespread use. In the 1930s, when Charnley was starting his career, orthopedics was still considered a minor specialty and did not initially attract the interest of Charnley's fertile and inventive mind. Among other assignments, while in the Royal Army Medical Corps during World War II, Charnley was stationed in Egypt and collaborated with engineers in developing various orthopedic braces and surgical instruments. On return to civilian life, Charnley focused his research on bone grafting, fracture healing, and ultimately on the weighty problem of total hip replacement. Twice his curiosity and inventiveness led him to experiment on himself, first by having a colleague place an experimental bone graft in Charnley's leg. Infection ensued and required several further operations before healing occurred. Later, Charnley injected wear debris from one of his total hip designs into his own thigh to observe the resultant inflammatory response. One day in the 1950s, a patient who had received a hip replacement by another surgeon commented to Charnley that every time he leaned forward at the dinner table, his hip squeaked loudly, which greatly disturbed his wife and prompted her to leave the room. This chance observation set Charnley off on a quest to perfect a low-friction total hip replacement, one that would not squeak. Charnley machined some of his early components at home on a lathe, which he had purchased using royalties gained from his previous inventions. He tried various hard plastics and settled on PTFE, trade name Teflon, for the socket side of the joint. PTFE did not squeak, and Charnley implanted it into 300 patients before its shortcomings became clear. Why that many? The PTFE was suitably durable during the first year, less so in the second, and not so in the third, when wear debris became problematic. The body recognized the debris particles produced by hip motion as foreign material and attacked them with a raging inflammatory response. The only recourse was to remove the artificial joint and all the surrounding havoc it had created. Charnley was distraught. He had wasted years and now had to occupy much of his time not making progress, but removing the failed implants. One day in 1963, not too long after Charnley recognized the shortcomings of PTFE, a salesman stopped by Charnley's hospital selling plastic gears, which came from Germany and were being introduced into machinery used in the weaving industry. He left a chunk of the little-known specialized plastic, polyethylene, an extremely hard and dense form, with the hospital's supply officer, who passed it on to Charnley's lab director. The investigator began immediately to test its wear properties, even though Charnley's initial response, after digging his thumb into it, was that the lab director was wasting his time. After 24/7 testing over 3 weeks, however, the material showed less wear than PTFE had shown in one day. Charnley noted later, "We were on." 2 other major hurdles still confronted Charnley. The first was how to solve the problem of securing the artificial components to bone such that the implants would not loosen and fail. No glue would stick to wet bone. Dentists, however, had successfully used acrylic cement to secure implants to jaw bones, and Charnley recognized its potential role in total hip arthroplasty. At the time of implantation, he mixed powder and liquid forms of the acrylic into a creamy paste and used it to fill any irregularities between the bone and the implant. Essentially grout rather than adhesive, the acrylic allowed for wide and even distribution of body weight forces between the artificial hip components and the bone. It worked, and it is still used today. By the way, the same acrylic shows up in manufactured products under trade names such as plexiglass and lucite. The other problem that hounded all investigators attempting total hip replacement was bacteria. Implanting these sizable metal and polyethylene components through large incisions greatly disposed total hip replacement surgery to wound infections, far more so than most other operations. When the early hip replacements became infected, the only recourse was to tediously remove the components and chip out all of the cement. This left the patients no better off than if they had merely had their joint cut away in the first place. Bacteria floating in the operating room air are inevitable, and some settle into the wound or on the surgical instruments, which can then transfer them into the wound. Charnley devised a 3-prong attack to minimize the exposure. He devised spacesuits to be worn by all the operating room personnel. Each person thereby was completely isolated from the wound, which completely alleviated issues of bacterial contamination from loose hair, sneezing, or even breathing. Each spacesuit had its own ventilation system to keep the user comfortable. Then Charnley added highly efficient filters to the room's ventilation system, which cleansed the air entering the room of nearly every bacterium and dust particle. Finally, the filtered area was channeled into a laminar flow pattern, such that the cleanest air in the room was always in the vicinity of the surgical incision. Thereby, any bacteria were zephyred away from the incision and out of harm's way. By the late 1960s, Charnley had worked out the problems just discussed, and total hip replacement became practical and safe. Orthopedic surgeons worldwide beat a path to his door to learn how to do the procedure. Before they could return home with a set of Charnley's instruments, he insisted that they take a 2.5-day course and pass a test covering his methods, both for the operation itself, but also for meticulous record keeping. Today, the composition and shape of total hip implants continue to undergo refinement, as do the surgical techniques for implantation. Over 300,000 total hips are implanted annually in the United States, and nearly 1% of Americans have one. With respect to improvements in quality of life, total hip arthroplasty compares favorably to the benefits bestowed by the treatment of high blood pressure with medication, chronic kidney failure by dialysis, and coronary artery disease by stents and bypass grafting. Charnley was knighted in 1977 for his contributions. Other investigators have extended his pioneering work, and more recent advances include development of similarly successful replacements for arthritic knees and shoulders. When individuals are otherwise healthy, a severely arthritic and painful large joint is debilitating. With every movement, it reminds the owners of their frailty. Sir John's contributions to modern medicine were monumental. That's it for today. I'm Roy Meals. Have a look at the blog, www.aboutbone.com, for many more interesting stories about bone.